That is Cushing syndrome. Cushing syndrome, very, very important question from the exam point of view. And easy diagnosis also, if you pay attention right now in the class, you can see this type of patient and you can say, yes, this patient looks like Cushing syndrome patient from a distance. So Cushing syndrome is the term used to describe the clinical state of increased free circulating glucocorticoid. So what is this? See here, it is a clinical state of increased free circulating glucocorticoid. There is excessive amount of glucocorticoid or cortisol inside the body in case of Cushing syndrome. It occurs most often following the therapeutic administration of synthetic steroid or ACTs these days. There are so many disorders which needs the use of corticosteroid these days, and they need to be used for a relatively prolonged period of time. And see what they do, okay, to our body. They can cause Cushing syndrome. Now, what are the causes? So one of the important causes you have just seen, okay? But what else? What are the other? We have roughly divided these causes into two groups: ACTH dependent disease and non-ACTH dependent causes. So ACTH dependent disease, this is definitely depending on the ACTH, means more ACTH should be there, and that ACTH is stimulating, okay, the adrenal gland, so that more cortisol is produced. This is not ACTH dependent diseases. One of that is called Cushing's disease, where pituitary tumor is there usually in the pituitary gland, and that pituitary tumor is producing more ACTH. This is known as Cushing's disease. Remember the term. It is not known as Cushing syndrome. It is known as Cushing's disease. Second, ectopic ACTH producing tumor. Now, which tumor commonly produces ACTH as paraneoplastic syndrome? Which tumors are those?
Pituitary carcinoma,
lung carcinoma,
lung carcinoma, bronchogenic carcinoma,
Adenomas.
bronchogenic
Bronchogenic
carcinoma.
carcinoma.
Very good. Very good.
Paraneoplastic.
They are small cell carcinoma or bronchogenic carcinoma, you can say. Very good. Bronchogenic carcinoma, especially the small cell carcinoma. They produce ACTH like a substance, which is known as ectopic secretion of ACTH. So this is an example of paraneoplastic syndrome. And the third one is we are giving ACTH from outside, okay, as a supplementation for a longer duration probably. So these are the ACTH dependent diseases. Now, non-ACTH dependent causes are adrenal adenoma, adrenal carcinoma, and glucocorticoid administration from outside. So these are non-ACTH dependent, and they are also important here. Now, what are the clinical features of Cushing syndrome? Okay, there are so many clinical features in Cushing syndrome because of the overall effect of excessive glucocorticoids in the body. Now, the common symptoms are weight gain. Okay, this weight gain is a central type of weight gain. I've already told you. This is also known as central adiposity. Okay. The fat from the periphery or especially the limbs, okay, are migrated towards the central part of the body. There is change of appearance in the patient. This is known as moon face. Okay, the face become rounded because of deposition of the fat again. This is called moon face, rounded face, and that face looks very, very red in color. This is known as plethoric face, rounded and plethoric face. Depression, quite common. Excessive amount of glucocorticoid can lead to this type of problem. Insomnia, okay, lack of sleep. Amenorrhea or oligomenorrhea can be seen in case of female. Poor libido, okay, poor libido, thin skin or easy bruisability, excessive hair growth or acne, along with glucocorticoids. A bit of sex steroids are also high in this disorder. So these are the clinical features of that: excessive hair growth or acne vulgaris, muscle weakness, growth arrest in children, very very important feature. This is what happens because of excessive glucocorticoid. They do not allow that growth plate, okay, to expand or to grow. Back pain because of osteoporosis, and polyuria and polydipsia. These are the effect in the kidney. This is because of chronic hypokalemia. Okay, occurs because of chronic hypokalemia. Now remember why hypokalemia occurs here. Very easy explanation. Cortisol has mineralocorticoid-like activity, and mineralocorticoid is retaining more sodium and excreting more potassium. So there is the condition of hypokalemia, and chronic hypokalemia can cause polyuria. As a result of that, polydipsia can happen. Now, this picture is a very classical one and very easy for us to remember as well. Now, all of you, please pay attention here. So let's talk about it. These are the important clinical features of Cushing syndrome. Personality change, okay, because of effect of the glucocorticoids on the brain. Red face as well as rounded face. This is known as moon face. Okay, rounded and red face. Very, very typical feature. This is how we suspect a Cushing syndrome case, This is known as Cushingoid appearance. Cushingoid appearance. Let me write that here. Now, one small point here. In the treatment of nephrotic syndrome, we give corticosteroid for a long time to the child. And after a few weeks, the child's face exactly looks like this. It looks swollen, it looks rounded, and it looks quite red. So this is known as Cushingoid face or Cushingoid appearance. Now, there is a chance of hyperglycemia. Okay, there is a chance of hyperglycemia. Addison's disease causes hypoglycemia, whereas Cushing syndrome causes hyperglycemia. We all know the reason. So this can also lead to secondary diabetes. There is increased susceptibility to infection. No need for any explanation. This is what is known as immunosuppression. Excessive steroid can cause immunosuppression in our body. There is fluid retention, which can lead to edema. Thin extremities, because fat are migrated from the extremities towards the trunk or central or truncal part of the body. In male, there will be gynecomastia. There is fat deposition on abdomen and back of the neck. This is known as buffalo hump. On the back of the neck, around the shoulder area, there is pad of fat deposition, and this is known as buffalo hump. Another important term in case of Cushing syndrome. There is striae. Striae are stretching formation on the skin. The skins actually, okay, are stretched. Okay, so they exactly looks like this splitting type on the skin. Striae. A bit looks like a pregnancy, in pregnant condition also this type of condition is seen. This is known as stria gravidarum in case of pregnancy, but in Cushing syndrome similar type of situation occurs. Cushing syndrome is one of the important causes of hyperacidity because the glucocorticoid has a stimulatory action or effect on hydrochloric acid secretion. In case of female, they suffer from amenorrhea or hirsutism. There is excessive hair growth on the face, an unwanted part of the body. Skin is atrophied, so it looks very thin. There is bruises and petechiae, again because of very thin skin, because of inhibition of protein synthesis. Probably some of the blood vessel may rupture and there may be a bleeding spot. And osteoporosis is a very common feature in case of Cushing syndrome. So there is an increased risk of fracture. Okay, not only in the extremity, the fractures are quite common in the vertebra on the back as well. So very uh, important type of picture, which is telling us a lot of important features of symptoms and signs regarding Cushing syndrome. Now, once again, let's repeat them. Moon face, don't forget about it. Kyphosis, okay, kyphosis again as a result of osteoporosis. Kyphosis is a forward bending, we all know that. Plethora, okay, means red face. Buffalo hump, deposition of pad of fat near the shoulder or back of neck. Depression as well as psychosis may occur in the patient, both. These are the effects of excessive glucocorticoids. Acne, okay, a bit of excessive sex steroid now. Central obesity or truncal obesity, we say. Hirsutism, again because of excessive androgen. Striae, purple or red, because of splitting of the skin as a result of decreased protein synthesis. Frontal balding in case of female, again because of androgen effect. Thin skin, bruising, and proximal myopathy all are related with decreased protein synthesis. Poor wound healing, again related to decreased protein synthesis. Proximal muscle wasting, same explanation. Pigmentation, okay, pigmentation again associated with ACTH, because ACTH is also high in this case, especially in the secondary type of Cushing's disease. Glycosuria, this is a hyperglycemic condition, so excessive glucose may be excreted in the urine. Skin infection because of immunosuppressive condition. Hypertension, quite common feature of Cushing's syndrome because of sodium retention in the body, sodium and water retention in the body, as a result of steroid as well. Osteoporosis, already talked about, and importantly, pathological fracture, especially vertebra and rib, as well as other parts of the limb. Okay, so repeat these signs more than once so that you can remember them easily. Now look at some of the picture here. So what can you see here in this lady? Yes, what are the signs you can see?
Buffalo hump. Buffalo hump.
Swollen
Moon
Buffalo
face.
hump.
buffalo hum.
The face looks moon shaped, like
Moon shape. Red.
Very good, excellent. Many students have already picked the point. See, this is called buffalo hump. Look at this, deposition of fat here, okay, on the back of the neck, upper shoulder area or upper back. Buffalo hump. She has got swollen face. See, look at fat is deposited here also, okay, on this side. It looks a bit red, that is plethoric. And one important thing, see this is hirsutism. Look here, okay, a bit of hirsutism. Also I can see a little bit of hair growth on the upper lip, okay, and on the face. So these are the stria formation on the patient, very typical of Cushing syndrome. And look at this, these stria are very wide, okay. These are very wide, very typical one. Now, what investigation we like to do in a case of Cushing syndrome? So we need to confirm that these things are happening here. One of the tests is known as 48-hour low dose dexamethasone test. Now, dexamethasone is a powerful type of corticosteroid, the synthetic type of corticosteroid. Now, see here, normal individual suppress plasma cortisol to less than 50 nanomole per liter when we give dexamethasone, because it will suppress hypothalamo pituitary adrenal axis. So plasma cortisol is very suppressed in normal people, I'm talking about. Whereas patients with Cushing syndrome fail to show the complete suppression of plasma cortisol level, because there is excessive secretion of cortisol from the adrenal gland. This test is highly sensitive. The sensitivity is more than 97%. So this is a good test to do. Another one is 24-hour urinary free cortisol measurement. This is simple but less reliable. Okay, there's a lot of determinant probably. This can be done nevertheless. Now, another is a circadian rhythm. And the meaning of circadian rhythm is we draw the sample and then check for that cortisol level in a different part or time of the day. See this. After 48 hours in the hospital, cortisol samples are taken at 9-hour and 24-hour without warning, without explaining to the patient what we are doing. We have to do this type of test. So 9 a.m. and exactly midnight. Normal subjects show a pronounced circadian variation. We all know at 9 a.m. it is maximum, and 24-hour means 12, midnight it is minimum. Those with Cushing syndrome have high midnight cortisol level. That is quite rare with the normal people, but this is a Cushing syndrome case. So in the midnight sample also, the cortisol level is quite high. Okay, so this strongly suggests us that there is a large release of corticosteroid inside the body. Now, some other investigation we can go for is Adrenal Ct or Mri scan. Now, remember, adrenal adenoma or adrenal carcinoma are some of the important causes of Cushing syndrome. Okay, so we have to go for this type of test just to detect them. And we can see what is the size there. Okay, are there any other signs of infiltration or even metastasis if the tumor or malignancy has come there from outside? Bilateral adrenal hyperplasia may be seen in ACTH dependent causes or in ACTH independent nodular hyperplasia, because ACTH stimulate both adrenal gland, not only one. So bilateral adrenal hyperplasia may be seen if these are the causes. If you believe pituitary tumor is responsible for Cushing's disease, then go for pituitary MRI. Pituitary MRI, which will definitely show a pituitary adenoma there. Now, what are the other type of tests? See here, we can go for plasma potassium level measurement, and this is a case where hypokalemia is common. Okay, every student know how to explain this now. We can go for high dose dexamethasone test. Okay, high dose dexamethasone test, and failure of significant plasma cortisol suppression suggests an ectopic source of ACTH or an adrenal tumor. Okay, so ectopic source it suggests. What does that mean? Failure of significant plasma cortisol suppression suggests an ectopic source of ACTH or an adrenal tumor, because they are independent, type of tumors. They don't depend on the ACTH for their stimulation or secretion of the hormone. Another is plasma ACTH level. Low or undetectable ACTH level, that is less than 10 nanogram per liter on 2 or more occasions, are a reliable indicator of non-ACTH dependent disease, mainly the adrenal diseases, which do not depend on excessive ACTH level. Means you just try to find out what is the cause of Cushing syndrome here. Now, some other investigations are Crs test. So this Crs test is done, okay, to know where is the problem, where is it in the pituitary gland or not. So an exaggerated ACTH and cortisol response to exogenous Crs suggests pituitary dependent Cushing's disease, because we are stimulating that pituitary gland with CRH. Okay, so that is the meaning. And chest X-ray is always done to look for paraneoplastic syndrome. That is the thing in case of carcinoma of the bronchi, or bronchogenic carcinoma, or small cell carcinoma of the lung. And sometimes even bronchial carcinoid can produce that. Now, let's talk about the treatment in today's class. Okay, now see this. Untreated Cushing syndrome has a very bad prognosis. Usually, the patient has a very bad prognosis, with death from hypertension, myocardial infarction, infection, and heart failure. So we can explain all of this. Hypertension is a non-feature of Cushing syndrome, and if there is a chronic hypertension, it will lead to heart failure because of hypertensive heart disease. Another explanation you can give: hypertension is an important risk factor for myocardial infarction, and myocardial infarction itself can lead to heart failure. Okay, infection is quite common in Cushing syndrome because it is immunocompromised situation. Remember, whenever there is excessive steroid in the body, that person becomes immunosuppressed. So infections are quite common. Whatever the underlying cause, cortisol hypersecretion should be controlled prior to surgery or radiotherapy. And that is done by some of the drugs. Okay, it is just like doing surgery in hyperthyroid case. Remember, before doing hyperthyroid surgery, okay, which is known as subtotal thyroidectomy, you need to control the release of thyroid hormone, and that is done by potassium iodide drug. Same principle here, but here the common drug we use are metirapone, and ketoconazole. Now, this metirapone and ketoconazole block one particular enzyme there, which is known as 11-beta hydroxylase. This enzyme is actively participating, okay, in the process of cortisol formation. So when we block this enzyme, cortisol doesn't form properly. Let's move on. Now, what are the other modalities of the treatment of Cushing syndrome? Transsphenoidal removal of the tumor is the treatment of choice in case of Cushing's disease, because there is a tumor in the pituitary gland and we need to remove it. This is known as transsphenoidal removal of the tumor. Overall, the pituitary surgery by this transsphenoidal removal results in a remission in 75 to 80% of the cases, but results vary considerably, and experienced surgeon is essential. Okay, so the meaning is it has a good prognosis, 75 to 80% chance of remission, and remission is a state of cure. The patient is all right now, so this is a good surgery to do. But of course, this pituitary gland is present inside the cranial cavity. There are so many important structures surrounding it, so very experienced surgeon is necessary. Another way of treatment is external pituitary irradiation. This is known as radiotherapy. If there is a tumor, we can destroy that tumor with radiotherapy. But this radiotherapy is effective in 50 to 60%, even after the prolonged follow-up. Now, this radiotherapy is not very commonly used, because it has so many side effects. It can damage the healthy tissue which are near to that area. And there are, we are talking about the area of cranial cavity or the brain actually. Okay, so as far as possible, this type of therapy is not commonly employed. Children, however, respond much better to radiotherapy, and 80% being cured. But this disease is not common in children. Now, what are the other way? The medical therapy can be given to reduce the ACTH level, like bromocriptine and cyproheptadine. These are the drugs which reduce ACTH level. Bromocriptine and cyproheptadine. Okay, the cyproheptadine is a type of antihistamine. And one important use of cyproheptadine in clinical practice is when the person loses the appetite, when the person, develops anorexia without any known reason, we can try a cyproheptadine for a short duration so that it can stimulate the hunger. But it has some side effect. You all know it's antihistamine drug, so long-term use is not advisable. And bromocriptine, where you use bromocriptine drug? Yes.
Hyperprolactinemia.
Hyperprolactinemia.
Very good, excellent. Okay, I will talk about that later on in the pituitary disorder. This is a drug which is used in the treatment of hyperprolactinemia or galacturia, okay, which is a hormonal disorder. Another way of treatment is bilateral adrenalectomy. Now, this is a massive type of surgery. You are removing both adrenal gland. This is an effective but very last resort when all other measures fail. We are talking about the removal of the adrenal gland, and adrenal gland are a very important organ, okay, of our body. They have so many important functions. So definitely, to save the life of the patient, if everything else fail, then only we need to go for that option. And these days, this can be performed laparoscopically. Now, listen properly. I'm going to say a bit more about the effect of this bilateral adrenalectomy. Now, see here, if we remove both adrenal gland, the negative feedback given by the cortisol doesn't exist, because cortisol is not coming out from the adrenal gland now because we have already removed it, right? So there is no negative feedback, no negative feedback to the pituitary gland. Because of this, okay, because of this, the cells which are there in the anterior pituitary gland, okay, you call them, what is the name of those cells which secrete ACTH? Isn't it? Corticotroph. Okay, they are called corticotroph. Those corticotroph cells will increase in size. They increase in size and they form a tumor. This tumor is a type of macroadenoma. This tumor is a type of macroadenoma, means it is a relatively bigger size tumor. That is the meaning. And this condition overall is called Nelson syndrome. Nelson syndrome. This can be asked as a question in your exam. Nelson syndrome. Okay, remember this. Now, let me explain this once again. So what happens here? When we remove both adrenal gland, there is no negative feedback. So ACTH hormone is excessively produced, and over a period of time, those cells which are producing ACTH will increase in size and form a tumor. This is known as Nelson syndrome. So what are the clinical features of Nelson syndrome? One, excessive ACTH production or secretion. Second, all the effect of that excessive ACTH secretion, a bit like Addison's disease now. Addison's disease, like hyperpigmentation will be there, isn't it? That's how we recognize this Nelson syndrome. And third, there has to be the history of adrenalectomy, bilateral adrenalectomy history should be there. And then this is a big tumor, so there is a problems of space occupying lesion inside the cranial cavity. The person may be having headache, blurring of the vision, okay, and other pressure symptom. Let's move on. Now, so what are the other types of treatment? Because there are so many causes of Cushing syndrome, that's why so many causes are there. So adrenal adenoma should be resected after achievement of clinical remission with metirapone or ketoconazole. These are the drugs which decrease the synthesis of cortisol. After that, we can remove the tumor. Whereas adrenal carcinoma are highly aggressive and the prognosis is poor because it's a malignant tumor now. So in general, if there are no widespread metastasis, then tumor bulk should be reduced surgically. This is a surgical principle of treatment of malignancy, isn't it? If metastasis has not occurred, we can remove the tumor safely. The adrenal-lytic drug called mitotane may inhibit growth of the tumor and prolong the survival, though it can cause nausea and ataxia. But these are not very important side effects. So mitotane can be used here. And then some would also give radiotherapy to the tumor bed after surgery. So radiotherapy is one of the options, but it has got some side effect, but nevertheless, treatment of the cancer is an important point here. Now, tumor which are secreting ACTH, okay, ectopically, means these are ectopic tumors, should be removed if possible. Otherwise, chemotherapy and radiotherapy may be used depending on the tumor. A good example here is bronchogenic carcinoma, small cell carcinoma of the lung. Okay, probably by the time this paraneoplastic syndrome is diagnosed, the tumor is already metastasized, but we can still go for this type of treatment. Control of the Cushing syndrome with metirapone or ketoconazole is beneficial for symptom, and bilateral adrenalectomy may be appropriate to give complete control of the Cushing syndrome. The prognosis from the tumor itself is reasonable. But having said that, this bilateral adrenalectomy is a massive surgery, and there are lots of problems. We just talked about it. Nelson syndrome will develop after this. So we need to decide accordingly, according to the patient. We cannot generalize the treatment process. Okay, so we have completed the discussion of Cushing syndrome.